Thank you for joining us today for our webinar. Your commitment to advancing mental health care is truly inspiring. At Iconotes, we're passionate about providing mental health professionals like you with the most clinically robust and intuitive mental health care software available. From psychiatrists to therapists, nurse practitioners to social workers, Iconotes offers a comprehensive solution tailored to your practice's needs. With Iconotes, you can write a flawless note in less than 3 minutes, and without typing a single word. Iconotes was designed specifically to help mental health professionals write comprehensive notes quickly. Iconotes also provides a complete practice management solution with user-friendly scheduling, secure document management, HIPAA-compliant messaging, a certified patient portal, and more, so you can spend less time on paperwork and more time helping your patients. Try us free at iconotes.com/try-us.
Welcome, everyone. We are so excited that you're here today. It's a beautiful morning here in Northwest Indiana. Thank you for everyone who's participating in the chat and letting us know where you're at. I saw that we have someone all the way from Sri Lanka in Puerto Rico. That's awesome. We're so glad you are here. I have no idea what time it is over in your area, but we are excited that you are joining us today. We have a great presentation for you today with Kaylee Kron, and she holds a Master's of Social Work and is a certified grief counselor through the American Institute for Healthcare Professionals. And for the past decade, she's worked to change the way we understand, process, and support grief. And she's a grief counselor at a local nonprofit hospice, and she has walked alongside grievers as a companion, uplifting each individual as the expert of their own story. And each person she met during this time further confirmed to her that we grieve so much more than losses suffered through the death of a loved one. And today, she continues her work as an author, public speaker, community organizer of large-scale events. And in these events, she helps create space for each attendee to look back at life at its most difficult moments and the pain they felt and say that it is grief. Kaylee's been featured in articles, podcasts, community trainings, online courses, and magazines, giving voice to feelings of grief and expanding our community's understanding of the many losses that cause grief throughout our lives. We've been so blessed to have Kaylee do multiple webinars with us so far and bringing on amazing guests. And so we're so happy that you're here again, Kaylee, to walk us through understanding post-traumatic stress disorder and grief. And welcome and thanks again. And I'll turn the mic on over to you.
Thanks so much, Angela. I appreciate that and your introduction of me. Just to clarify, I am not a current grief counselor at a local nonprofit hospice, but that is where I started my work in grief professionally. I did notice in the chat that there's somebody else here from Coeur d'Alene, and I found that thrilling. So welcome. I am living in North Idaho. A huge shout out to the nonprofit hospice that I worked with and developed many programs for. So if you are in the North Idaho area, definitely look them up. So we're going to get started on, understanding post-traumatic stress disorder and grief. But to start, I want to tell a story. So I think as a grief counselor, I had the privilege of walking alongside individuals who experienced some of the worst traumas of their lives. That included a grief experience and sometimes and often included post-traumatic stress disorder. And what I realized is that those two experiences they overlap with each other in such a significant way and can at times feel similar. And what I think I wanted to flag during this webinar is that one of these experiences is a natural, normal response that is universal to every single one of us. And the other is a disorder. And it is something that occurs based on a myriad of additional reasons that happen that go alongside with grief. You can have grief without PTSD, but there is grief inside of PTSD. So that is something I really want to speak to today. And that really came through in stories shared by parents who had lost children. And I want to take you through a story that I witnessed that has really stuck with me, that really rings true in my head when I think about these two experiences going together. I was really new to my trade as a grief counselor. And I had a woman come in who had lost her child 10 years before she came into my counseling room. Her child was 2 years old, and she witnessed a very traumatic incident and did not pursue any formal support following. So to watch your child die and then live with that trauma, grief, incredible loss for 10 years. What did she do? She experienced a lot of triggers, and we'll talk about that throughout this webinar, that is really common in PTSD and also grief to an extent. And so she numbed that through the use of substances, illicit behaviors, and anything else she did as a way to survive the trauma that she suffered in the absence of care. When she came into my office 10 years to the day of her child's death, her grief experience was so raw and so immediate that I realized this woman has been holding acute post-traumatic stress disorder and grief to the point where it didn't feel like we were going through a typical grief counseling experience. Sometimes when we experience grief, the PTSD, the trauma of it, floats to the surface and becomes the primary issue. That is not to say that every person that comes in had PTSD. And many of the people that I walked alongside in grief were able to participate in a grief counseling setting. But this woman in particular, I knew and I could flag that she needed something far more significant in her treatment process. And so that is all to say that we experience people coming in for reasons that they believe are at the top of mind. She came in because her child died and she was grieving. But I, as a clinician, had to differentially diagnose what was going on and realize that what she was needing was a trauma therapist first, and then grief could be addressed. So we're going to get started and kind of looking at that. I do see a hand raised, and if you have questions, put them in the Q&A box and I will get to them. We'll have a little bit of time at the end to kind of go over any questions that you have. But hopefully I get to them before that happens. So as Angela shared, I was a grief counselor through a local nonprofit hospice. I was very, very lucky to be able to work at a nonprofit which allowed community members who experience loss inside and outside of our hospice setting to come into my counseling room. And so I spent a lot of time with people who had lost a loved one through tragic accidents, suicide, overdoses, missing persons, the whole gamut. And I think it really showed me more than a traditional loss through death. It showed me very traumatic. But with that being said, the experience of trauma is individual. So I also had people whose loved ones died on hospice, which could be argued that the intention is that when you die on hospice, it is peaceful. That's not always everyone's experience. And as you witness your loved one dying, that can be traumatic in and of itself. And so really holding space for, throughout this webinar, the experience of trauma within PTSD is highly subjective. And so you can't say every single person who experiences this one incident will then go on to have PTSD. That's not the case. And so through my work as a grief counselor, I was really able to witness a myriad of levels of the overlap of PTSD and grief. So I wanted to talk about it because I do find it to be very, very important that we know the difference and we also know how they present similarly, and then how do we treat that moving forward. So we're going to first just establish a foundational understanding of both grief and PTSD. We're going to talk about signs and symptoms, what causes them, a little bit about the brain, and how that presents itself. The next thing we're going to do is my favorite thing, which is a Venn diagram. I love to look at how two different experiences or diagnoses overlap with each other and may mimic each other. There's many of those that present themselves throughout the DSM. However, PTSD and grief are very unique because they're not necessarily both disorders, right? And so we're looking at a natural, normal experience that happens as a result of someone being lost. And then we're looking at something that presents due to a number of additional factors within a loss or a traumatic event. And then we're going to look at assessment and treatment of both of these situations and how we support people kind of where they are at. So the first thing we're going to start with is grief. And I have always said, grief is a natural, normal response that individuals feel. I think in our culture, we have really developed a genuine discomfort for grief that makes it hard to work with. I always said as a grief counselor, my goal is to make my job irrelevant because I want to educate people on grief, on the foundations, on the experience, on the universality of it all. And I also want to educate people on our inherent ability as human beings to support another person in grief. My job exists because that's uncomfy, because grief, because we all experience it, we also struggle to support it because it is scary. It is impending, it's coming. And I think that that is something that we really struggle with. Even in a clinical setting, we want to treat it and we want to get it done and we want to work through it and find resolution. And grief is a fickle pickle, and it'll maintain, it'll persist, and grief is a long-term transformative experience. It is also an internal reaction to loss. So when we think about the difference between grief and mourning, those two things go together and they dance, but one is on the inside. Grief is an internal reaction. It's the thoughts, feelings, emotions. Mourning is that outward expression of everything happening on the inside. It is when we used to wear black after somebody died. It is crying. It is screaming. It is processing out loud. It's when you see it, that's mourning. When you show it to people, that's mourning. But everything happening on the inside, psychosocial, internal, emotional, physiological experiences, all of that is kind of going together within the grief process. And it isn't just one thing that's happening. And that's why it's so exhausting. If you've ever experienced grief, you know what I'm talking about. And again, it is a universal experience. It happens as a result of loving. So anyone who loves will grieve. And that is the universality of it. Features of grief. One thing to note is, I think it was back when I was in my master's program in like 2011, 12. There was conversation, well, the DSM-5 just came out, and there was a condition for further study called complex persistent bereavement disorder. And why did we want to be able to diagnose grief? There's a couple of reasons. Number one, we wanted to be able to bill for it. And so in order to bill for treatment of a condition within a counseling or therapy setting, we had to have a code. And so clinicians developing the DSM-1 through 4TR were really perplexed by grief. We knew it existed. We knew that it was an issue. And we also knew we couldn't bill for it. And why is that? And the reason is because it is such a unique experience for every single individual going through it. And so you can say cries or expresses grief 5 out of 7 days of the week. Is that true? For some, not for all. And so when we think about grief, we do have to kind of look at it through this umbrella lens of this may be how somebody presents in grief. But there are a lot of other factors, like are they expressive in their regular life? Are they kind of weepy in their regular life? Are they somebody who takes a lot of difficult things and kind of processes on the inside? So grief presents in different people in many, many different ways. And so it isn't necessarily something we can mark off on a checklist within our assessments. But we can pay attention to a couple of things, including the physical things that we typically see through grief are appetite changes that may mean lack of eating, and it may mean eating more, depending on the person. However, we do see a marked difference. Lethargy, feeling tired and weak. This is a pretty common experience across the board with grief because, as I said, grief work is a full internal system process and it is fundamentally exhausting. Our brains are working overtime trying to conceptualize and understand and absorb the reality of the loss. That takes all of our energy. So you'll often hear grievers say, I did nothing today and yet I am still exhausted. That is because they by no means did nothing. And so I always like to remind them, like, you are working so hard. So if you did anything today, that's great. That's a win. Trouble sleeping would also lend itself to the lethargy. But that trouble sleeping really surrounds the process of your brain really working overtime to understand the loss. So whether it is difficulty falling asleep, staying asleep, or having truly restful sleep, that is a bucket that we look at. We also have something called grief fog or grief brain, and we'll talk about that a little bit more within the brain, what happens to your brain in grief. But you'll have people saying, I don't know, I don't know what's wrong with me. I went to empty the dishwasher and then I forgot what I was doing halfway through. And then I come back into my kitchen hours later and my dishwasher is open and half empty and I don't know where I left off. And that is a super normal experience based on changes in the brain that we experience during grief. The emotional is something that we have a pretty big flashlight pointed on. When we talk about grief, there are so many schools of thought about the grief process and what it looks like. You know, you have Elizabeth Kubler-Ross who talks about the stages of grief. You have William Worden who talks about the tasks of mourning. If you're interested in going over that, we will be doing a full grief webinar in a few months, so please keep an eye out for that. But in general, things that we can kind of bucket into the grief experience include shock and disbelief related to the loss. What that means is we are humans and we are storytellers. And so we also, when we have our life going, we tell a story about what our life's going to look like moving forward. When there is a change that occurs, which includes death or many other types of losses, which we'll talk about in the next slide, our story that we told ourselves change. And that is a very difficult thing to integrate. And so you will go through moments where you drive home and the person who died's car is in the driveway and you'll think, they're home. And then you'll remember that they are not home, that their car is there because they died and their car will remain there. But we have these moments where we forget. Also disbelief. I can't believe that happened. I can't believe this is real are things that people say pretty commonly within the grief process. And it is a matter of integrating that story, the new story, into the story you told yourself about what your life would look like. We also have anger. Anger is a great tool in grief. We have to hit somebody with it. Whether we hit ourselves, we hit the person who died, we hit the doctors who treated them, we hit society that created the system in which they died. We are mad and we got to throw that anger around. And it is a completely natural, normal thing, although it makes us feel terrible when we reflect. I remember, as a griever myself, yelling at a Starbucks barista years and years ago. And I thought, that's not me. But it also reminded me that when I'm yelled at for no reason, maybe they're grieving, and maybe I'm the one they got to throw it at today. And so we really want to normalize that. Sadness, depression, and longing for the deceased is probably the marker, right? We have across the board, when we love somebody and they are gone, we're going to experience deep sadness. Depression, and I want to kind of point this out, depression and grief is not clinical depression. And the way that you know the difference is that in clinical depression, we don't always know what's causing that sadness. We don't always know why we're feeling so down. In depression through grief, we know the person died, or we lost something really significant to us. And so that's kind of how we differentiate those two experiences. And that is also really important because you don't necessarily want to take that feature of depression and then start treating somebody with clinical depression, because that is not what they are experiencing. And so to be able to really earmark and say, why? Is there a why to this feelings of depression? And if it's grief, then there you go. That's your route. I think, we can all agree that loss through death is the thing that we associate so closely with grief. However, when we think about that internal process, that feeling of grief, we can kind of pop open that box and say grief actually happens more commonly than we give it credit for. Grief is a natural response to someone or something being lost or taken. So again, because we're storytellers and we tell the story about what our life is going to look like moving forward, when any of those elements are ripped out with or without our permission, and there's a nuance to that, we have to figure out how to tell that story again. And there is grief within that. So just to pop a few out here, of course, divorce is going to elicit grief amongst many other things. But there is a story you told about how that marriage was going to go, how your life was going to look. And that also really folds into infertility, pregnancy loss. I saw a lot of grief related to chronic and life-limiting illnesses. So when you come into a hospice or a palliative care setting, the understanding is that you are experiencing an illness that is going to limit your life or fundamentally change the way you live your life. And there is so much grief associated with that when we think about how our bodies function, our ability to participate in the world as we did before that diagnosis. So think about grief in a way bigger way, and you will find grief in pretty much every client that you interact with. And it's poignant. So as I said, grief has a pretty massive impact on the brain, mainly because it is working so deeply hard to reintegrate this new story into the story that we tell. When we test the brain before and after grief, there are some changes with concentration, completing tasks, memory, and your ability to kind of organize your thoughts and make plans moving forward. All of those things put together leave a griever feeling really foggy and really unsure. So you can be talking to somebody who is experiencing acute grief, and they will kind of forget what we were talking about. And that's okay. And to just normalize and show patience, because sometimes those trains of thought derail as a result of all the extra work that the brain is doing to process that loss. So then moving into post-traumatic stress disorder, this is more complex, right? Because this isn't a natural, normal response that is universal and we all feel it. It is a diagnosis that occurs as a result of experiencing or witnessing what they perceive to be a terrifying experience. And that perception is a really important piece there. You can have 5 people experience the same car accident, and they will each respond and process that completely differently. And we're going to talk about kind of additional features that would lead someone into a diagnosis of post-traumatic stress disorder, but it includes temperament. It includes how do they solve problems in the past. It includes previous experiences with hard things and how was that processed? What is their tolerance to distress? All of those create a route into a PTSD diagnosis. But again, it is subjective. And that is not meant to minimize somebody's experience of trauma either. It is truly just how our brain processes it. This disorder is not time limited, unfortunately, and if it goes untreated, unsupported, then this can be really detrimental to a person's life. There are features and symptoms of this disorder that really impact somebody's ability to move forward and just participate in life. For example, if they witnessed a car accident or were in a car accident, they may be impacted to the point where they can't get in the car. And then how do you get groceries? How do you go to work? How do you visit your family? How do you stay engaged in life? And those are really important questions. We see that in general, trauma is pretty prevalent. 60% of men and 50% of women will experience trauma in their lifetime. I think that's incredibly high, and just goes to show that this life is hard, and we have to honor that. So when we look at that 60% of men, 50% of women, dial that all the way down to 6% of the population will then experience PTSD following a trauma. So that just goes to show that not everyone who experienced trauma will then get that diagnosis. The features of PTSD are poignant, for sure. So we have symptoms that include experiencing and re-experiencing that traumatic experience, and that can manifest through flashbacks while awake, nightmares while asleep, repetitive images, not being able to get the sight out of your mind, and then physical sensations. You'll have like feeling of being in that very traumatic situation again, overwhelmingly so. Situational avoidances, as I mentioned before, if you witness or are in a car accident, you are less likely to want to hop back into that motor vehicle or another one. So you'll stay away from anything that is associated with that trauma. Arousal and reactivity, people with PTSD maintain a pretty hyper aroused state. And so they're very reactive, very irritable. Any little thing is going to set them, because it's like you've got a scab or a cut and someone keeps scratching up that scab. It's so raw, and it really it's irritating for the person who's experiencing it, and they lack control of that reaction. They feel very tense or on guard, and of course have difficulty sleeping or staying asleep as a result of the nightmares, the flashbacks, the images, and that hyper aroused state. It's very difficult for them to rest. And you can imagine the impact that that has on somebody's brain and their mood. So moving into cognition and mood, they have difficulty concentrating, trouble remembering elements of the traumatic event, and they are angry, guilty, and feel potentially shame or guilt related to whatever that traumatic event is. And I think as clinicians, I'm sure you've seen many different people who have experienced traumas, and how we blame ourselves for trauma, how we feel that in some way we had something to do with it that caused it, is just another way we process through that pain. And it can be very upsetting to somebody who has experienced an incredibly traumatic situation. Causes of PTSD are multiple, so we're going to go through a couple of slides. So starting at the very beginning, there are genetic risk factors that would indicate that somebody has a higher likelihood to experience PTSD, which includes having a family member with a history of mental health problems. We can see kind of that intergenerational diagnoses of things like depression, bipolar disorder, and other conditions of the like, which kind of pair well with highly reactivity to distress. Having somebody in your family that has experienced a mental health concern will also pop that up and we'll talk about that within another slide. But certainly getting a family history during assessment would be really helpful in determining if PTSD is possible. The second piece, and I think this is a pretty important one, is just temperamental risks. As I mentioned, when we think about why do some people, when they experience trauma, then go on to have a diagnosis of PTSD when others do not? And it is a matter of responsiveness. How do we, in general, within our temperament, something we cannot control, experience difficulty? That starts through childhood. So when we have emotional challenges and vulnerability in childhood, when we are not supported, when things are difficult, and when hard things happen, based on our temperament, we will what? Fight, flight, freeze, fawn. So you really look at those different things of, tell me about another time that something hard has happened. Tell me about an early time something hard has happened. Also, if the person has experienced previous mental health issues, there is a co-occurring overlap there. And then, do they have a propensity to feel more depressed than the typical person based on everyday factors? Sorry, I need some water. Environmental risks are kind of looking into previous experiences around the loss, social supports that the person has, and how do they navigate the world today. So in a lot of these, you can see the early childhood issues would exacerbate the possibility of getting PTSD. And if you're familiar with anything like the ACE study, adverse childhood experiences like lower socioeconomic status, being exposed to traumas during childhood, exposure to adverse childhood experiences, family dysfunction, loss of a parent, those are all ACEs, meaning that the higher your ACE score, the more likely you are to experience PTSD in the wake of a trauma. You can also look at family dysfunction in a way of, are they supported when a traumatic experience happens? A lack of support would exacerbate the post-traumatic stress of it all, because you don't have somebody to talk to. You don't have a safe place to go to process what you went through. And so the lack of social support is significant. Cultural risks, it is shown that different cultures experience PTSD in different ways. There is a lot of research on it, and I would say if you really want to dive into an individual within a cultural experience, let's say Indigenous communities, they have experienced such intergenerational traumas that there is unique features within that community. And so it is important when working with specific cultures that you do a deep dive and you don't keep, I would say, cultural, like whatever your cultural identification is, don't keep that lens when working with others from different cultures, because they will present differently based on that as well. Sex and gender differences, as I mentioned before, more men will experience trauma by about 10%. However, women are more likely to, excuse me, are more likely to develop PTSD. This can be as a result of what kind of traumas women experience over men. And it can also be how women's brains work and how they process traumas differently with their cognition and emotionality. And that's not to say women are more emotional. It's just the way that we process our emotions. I want to flag that as well. And of course, PTSD has a significant impact on the brain. It changes the structure. And so when you look at the different areas like the prefrontal cortex, hippocampus, and amygdala, those have essential jobs that regulate, process, understand, and manage. So specifically, let's go into the amygdala. And we think emotional memories, regulates behavior, and initiates response to fear. That thing gets warped. And so when we look at the symptoms of very irritable, constant flashbacks and nightmares, that thing is just flagged. So then to make it as simple as possible, because I love a good Venn diagram, it's my favorite thing to find, is there are this like overlap in general emotional responses, impact on functioning, and like potential flashbacks, as well as the duration. So we'll go into those a little bit more, but the reaction is similar. But when you go out to those two circles, PTSD requires a triggering event, and it also has diagnostic criteria that an individual would need to meet in order to be diagnosed. When you go over to the grief section, this is a natural, normal response. It is non-pathological, and it is important to treat it as such. And it also is a universal experience, meaning we will all go through it. So in grief work, normalizing is an incredibly important component. And this is just another look at that with a little bit more detail. We have PTSD only has triggering events, how the symptoms present, the diagnostic criteria, and the treatment approaches. Treatment approaches are what we're going to tackle next. And it is very different than grief work. And then going into grief, it is a natural response, non-pathological. So really, it just depends on ease of reading, so that one or both of these formats would help kind of encapsulate. We also have a number of assessment tools that have been developed. Thankfully, neither of these are incredibly new experiences. And so there's been a lot of studies and a lot of assessment tools that have been developed to support the assessment and treatment of both of these. You can find many of these, but a lot of them are paid to get into or purchase so that you can use long-term. So if you're finding that you are seeing a lot of clients for grief or for PTSD, you'd want to really invest in one that is deep, but also customizable. Personally, for me, the grief response scale is pretty helpful. It helps kind of talk about acuity. And then on the PTSD tools, I think each of those are really helpful for different reasons, and just depending on what system you work off of. So there are different goals for the treatment of grief and the treatment of PTSD. What we want to overall do in grief work is help an individual accept the reality of the loss, process the pain, express the pain, engage their social supports, and reinvest in their story moving forward. We, of course, can look at more specific things like facilitating healthy grieving. What does that look like? And that can depend from person to person. We want to reduce grief symptoms, so that would include ways to tune in and tune out. There's a lot of research around when we grieve, being able to kind of oscillate between really diving into the pain of it and then taking a break, because grief work is so exhausting and difficult and transformative that sometimes we just need a break from that. So helping normalize that as well. We overall want to normalize the grief experience, but then also think through Long term, what does grief look like for you as you integrate this experience into your journey moving forward? Social connection is also incredibly important in grief work. Um, they say that all you need is one person who is really going to listen, who you can lean on, who you can call when you're having a hard time. And so helping someone locate a person, and if they do not have social supports, get them in support groups, get them into one-on-ones, and make sure that they have somebody who can hear them. So we have a couple approaches to grief work, and this absolutely is unique to each individual. Not everybody is going to need formal support in grief, and I think that's really important to note. Many times, in like 70% of all grief, you process that and you engage your social supports and you have what you need and you're good to go. And that other percentage, there's a mixture of people who need help navigating social supports, who want more information and want to be able to think through their grief process. There are people who just need somebody to talk to. And so that kind of percentage is what falls into these categories. We have grief counseling, and I should have added companioning as well. Because grief counseling and grief companioning is a very different approach to a therapeutic relationship. It is not therapist-client. What we want to do in grief is go side by side. Grief counseling or grief companioning is you are the expert of your experience. Let's talk through it and let's experience this together and work through whatever your questions are. It can be unpredictable, and really following a client's lead within that is super important. The other thing that is very, very helpful in grief is engaging in support groups. Not everybody's going to be open to this, and that is okay. But what grief support groups do is mitigate that isolation that people typically feel within the grief process. Grief makes us feel like we're the only people experiencing something. So when we can dive into a group setting where multiple people are experiencing that, that is very helpful, very normalizing. And then cognitive behavioral therapy for grief is for people with acute grief, complicated grief. It's at the next step up. So it's important to not jump all the way to therapy, because counseling can often support people with what they need. And then that highest acuity is, of course, medications associated with the symptoms, but that is always a doctor call and not a counselor call. We also have goals for the treatment of PTSD. Many of them are similar, like reducing the symptoms, improving daily functioning, enhancing coping skills. But we also think through the ways that we process and integrate traumatic memories. How do we help somebody with those flashbacks, nightmares, images? And so there's a couple ways we do that, and we'll talk about that in the types. But really what we're looking for is helping someone be less reactive to the traumatic flashbacks and experiences and symptoms. And so we want to increase their tolerance and help them process through what happened. And we do that through, starts out at a pretty high acuity, and more people experience PTSD. I'm not going to say everyone, because I don't think there's always an answer for everything. But many, many, many people who experience PTSD do need formal support because of how interferent the symptoms are in daily life. So we jump right to psychotherapy. Cognitive behavioral therapy can really help because it is the process of like changing your thoughts and then behavior. So your cognition, thoughts, behaviors, and we reroute how people are experiencing that trauma, and we work through in each stage. And then EMDR has been shown to be very supportive within grief to an extent, but absolutely PTSD, medications can be helpful. And then there's emerging therapies that help with, exposure to the traumatic event, working through that distress tolerance, and virtual reality has also been used, which is a really interesting modality that is not brand new, but it feels pretty new. And I rushed that last part and I do apologize. But I am going to hop over to the Q&A section. So I have one question, so feel free to drop any more questions. I'll talk for about 10 more minutes and then we're going to have a presentation on the software. So the question I have is there a correlation between or with grief and sudden risk-taking behaviors? Yes. In short, yes. And I want to kind of pop that open a little bit because it's not just yes. It is when we experience grief, it pulls our world down. It changes the story that we are telling. It makes us feel unsafe. Living in an unpredictable world, and we're very distressed and unanchored. And when we're feeling activated in that way, we are likely going to revert to any coping behaviors that have helped us in the past. So if somebody is someone who engaged in drinking or drugs, that would likely be where they default to. If they engaged in risky behaviors before, that might be where they default to. We are not our highest self when we're grieving. We're really in this survival mode. And so what was that for them? And likely just kind of leaning back into that. So that's not to say all of the sudden they'll be very risky. That can't happen. And we all experience grief differently. But what I have said, when people finally come to grief counseling, they're typically feeling like, I don't want to do what I've been doing to process this anymore, and I need help figuring out a different way. And as a grief counselor, just always normalizing and saying, listen, you did what you needed to do to survive. And here we are, and let's move forward. The next question, how effective do you find person-centered therapy for grief and PTSD? I find it more useful for grief, absolutely. PTSD, I think, really very specific modalities that target those symptoms, the traumatic experience and that kind of thing are really important. However, person-centered therapy, all that grief work is on the individual. So we're looking at, how are you feeling? How are you doing? Tell me what brings you here today. And just allowing them to lead has always been what I default to within any grief counseling setting. And what I call it, and I didn't create this by any means, but it is the companioning model of grief. It really centers the individual, and it kind of keeps the clinician or the therapist or the counselor or the support person kind of off to the side, and it really shines a spotlight on that one individual and everything they're thinking, feeling, doing, needing. The next question is, have you seen spirituality help or harm an individual? Oh my goodness. I have always said one of my favorite parts of being a grief counselor was that I had been exposed to so many different individual spiritual practices, religion, paths to and from God. And it is so unique to each individual. I have seen faith be very, very helpful to some. And I have seen some gravitate toward faith, toward belief in a higher power. Individuals who previously did not really believe in much of anything feel a need to then invest in the potential for an afterlife and spirituality because that's how they stayed connected to their loved one. I have seen that. And I have also seen faith, spirituality, and formal religion be harmful to individuals, specifically around God's plan. And the platitudes that we say in grief, in times of deep pain, where we kind of remove our emotions, or we're called to remove our emotions from that process, because it is God's plan. There's a plan for everything. Everything's on purpose. Everything's intentional. And so to grieve or to express anger about that plan doesn't feel right to someone in an organized religion that has taught them that, like, you're supposed to trust God. And if you are angry, that means you're not trusting God. And I've seen a lot of grief be pushed down and suppressed as a result of that. And it has never been my goal to change someone's faith, religion, spiritual practices. And so we try to work within whatever framework they are comfortable in. And so I have seen it help and I have seen it harm. And regardless of that, meeting a person where they're at and not trying to change what they're thinking or feeling, because it is their process and it is their journey and it is also their faith. And that is very important to many, many people. Okay, I'm trying to read through all these because I have about 4 minutes left to answer these questions. Okay, when there are multiple issues that occur consecutively, how would this be approached in treatment? And this is one of my favorite imageries that I like to use for the millennials and older. In your car back in the day, or maybe your current car, and I commend you for that, is a 5-disc CD changer. And you have 5 discs in there. You have 5 CDs, and in life, in that co-occurring situation, like let's say the co-occurring is PTSD and grief. Depending on the day, depending on what the needs are that are presenting on that particular day, that is what I address. So as a therapist or a clinician, you might have an idea of what you are approaching with your client that day based on a conversation you had at your last session. They come in and their priorities have shifted, whether that is you were managing symptoms associated with PTSD, but they come into your session and they are sad and they are grieving and they deeply need to be heard. It would not be helpful to say, okay, we knew that for a little bit, but this is actually what our plan is. So really just following the person's lead, and whatever disc starts to play is what you respond to. I hope that's helpful. Let's see. I have time for one more. Oh, can you elaborate more and give an example on grief companioning? Absolutely. It is my favorite thing to talk about. Grief companioning was a therapeutic modality created by Dr. Alan Wolfelt. You can find all of his information at the Center for Loss and Life Transition. He's out of Fort Collins, Colorado. What he realized is that we were pathologizing grief and saying that this was a problem to be solved. Because we live within the medical model, we live within a therapeutic model, that was kind of how grief was being treated. What he did was a lot of research around how were people supported in grief a long, long time ago, and what has been lost. And what has been lost is sitting with a person, bearing witness to their pain, and in no way trying to change it. Normalizing what they're going through and allowing them to lead their own grief journey, and saying that you are the expert of your experience, not me. And so in the simplest terms, as a grief counselor, someone comes into my office and I say, I am not the expert on your experience, you are. So why don't you tell me a little bit about what's going on and let's walk together. And that walk can be real, or it can be a euphemism for let's go on this journey together. It's a lot of reflecting back. It's a lot of meeting people where they are. But if you want to learn more about it, go to the Center for Loss and Life Transition. Alan Wolfelt is my personal guru. And with all of that being said, I did have a question about sharing my email. If you have any additional questions, I'm more than happy to share them. So I'll put that in the chat. And then I am going to pass it over to October, who's going to do a presentation on the software. Thank you all so much for signing up for this webinar. I hope that you got what you needed out of this. And I will be looking at the questions to kind of see what other interests people might have in this topic and related. So thank you so much.
Thank you, Kaylee. That was absolutely wonderful. Thank you. Thank you. Did an excellent job. And I can tell from the comments, everybody feels that way. So that is amazing. And thank you guys so much for joining today. So I'm just going to be sharing my screen really quickly. Can everybody hear me okay? If you can, if you could please type yes in the chat. So, all right, fantastic. So what I'm going to be showing is going to be, thank you. All right, fantastic, fantastic. So what I'm going to be showing is Iconotes, and this is Iconotes Plus. So if you're a current Iconotes Classic user, this is going to be a Plus version. So this is going to be a great little intro into that. And it does look a lot different than Iconotes Classic. It's very pretty. But I'll go into Jeff Blue's chart, and I just want to continue along the theme that we are talking about today, and that is going to be grief. So I'm going to go into a progress note, and I'm going to pull up Jeff Blue. And this is a prescriber note, but we also have therapist notes. They're very similar, but they obviously have different language. But I'm going to say the client has symptoms of, and we're going to put grief. And I'm going to say that grief is definitely present. And I'm going to say that unfortunately that's chronic. They're going through chronic grief, maybe that prolonged grief. And so I can say that we have crying, and that symptom is present, and we have some irritability, and that's absolutely present. And then they're preoccupied with the loss, and that symptom continues and is much worse. They're yearning for the individual, and that symptom continues and it's about the same. And then I'm going to talk about physical symptoms. Maybe they're having chest pain, and that's present. There's definitely some fatigue going on, and that symptom continues and is about the same. And I can talk about maybe they are having some social withdrawal, and that symptom is absolutely present. I can talk about behavior as well. Maybe their functioning of work is marginal. I can say that as far as substance use, it's more than advised. I can talk about their anger is poorly controlled, impulses are probably poorly controlled, and they're having problems with sleep problems like falling asleep and staying asleep. And then I can go in and start talking about verbal content. And obviously, there's a problem. We can say that there's a problem within the family, and there's grief happening, and that's causing some low self-esteem and definitely some anxiety. And then I can talk about psychotherapy, what I'm going to do. So our session goal is going to be coping skills and working on self-esteem. Our interventions are going to be working with it could be the source of their feelings, or supporting them and allowing them to vent their feelings. And then I'm also going to go in and I can talk about justify level of care. I can say that their outpatient is still needed, especially if you're working with insurance companies. And I can say that that interferes with their day-to-day function, and they require continued treatment, maybe to get more sessions in for them. And then I can link that treatment plan in. Iconotes has a robust treatment plan, so I'll link in that grief treatment plan. Grief and losses is especially helpful if you're dealing with Medicaid or Medicare patients, linking that treatment plan right into the note. And I can say that, they're making some moderate progress or maybe some fair progress on the treatment plan. And then we're going to continue the plan because maybe current progress is seen. But sometimes you're going to have individuals that are not making apparent progress, right? You might have the best short-term goals and long-term goal for them, but they're just not working on those. And so we can say that maybe the problem is worse, or that's not getting better, and we need to continue. We need more time with that treatment plan, or we're going to be changing that treatment plan. So, and then once I hit that, I can go ahead and link that into my notes, and then I can compile and preview. And what you'll see is it looks like that I have been typing, and you can type in this yellow field. I just want you to know that you absolutely can type in anywhere in the yellow field. You can type to your heart's content. You can dictate into there whatever you'd like. You can cut and paste into these fields. but this is just using our shrub buttons, which iCanotes is known for. And this is not AI. These are not statements you get. You don't know what AI puts into that. I don't know if that's ever happened to y'all, but AI can sometimes throw things in there that has nothing to do with what you were talking about. But these are clinician created statements. And I have a beautiful note that I've created with the treatment plan directly in the note. So, and I can electronically sign that. I can copy it to a clipboard if I'm using another EHR. And this is our notes. We have a calendar with online scheduling in it. You can order, if you're ordering labs, you can absolutely do that. We have nice reporting in the system, and we have a fantastic dashboard that shows you notes that you started, maybe you didn't finish. So it helps you keep track of the notes that you're creating. So this is iCanotes. This is our plus version. We also have a really robust classic version, but I wanted to give you the opportunity to see that today. So I hope that was a little helpful. And Kaylee, thank you again for everything. So, and if you're interested in iCanotes Plus, we're happy to demonstrate it for you if you think this would be a good need for your practice. So, all right. Thank you. Yes, it does. It saves you a lot of time. Note creation, you saw that I took you through a note and explained how to do it in just a few minutes. Note creation usually is 1 to 2 minutes. So, absolutely. Exactly. Exactly. So, it's a very helpful program. It's great. It's a great program if you're starting out, but it's also a really helpful program to save time as well, if you've been in the field for a long time. So, yes, it absolutely does. So, and thank you guys so much for attending today. I hope everybody has a wonderful Thursday. And again, Kaylee, thank you so much. So, what's a wonderful, wonderful webinar. All right, y'all have a fantastic day.